Welcome to the funnel effect.
Thank you. It's really great to be here for this one.
Yeah, I'm super excited about today's topic because we're standing at the edge of this massive shift in medical history today. We are looking at one of those moments where the tectonic plates of cardiology kind of just shifted and the whole landscape changed forever.
Right. It's not just another incremental step.
Exactly. We are not just talking about a new pill or a slight tweak to a procedure. We're talking about a fundamental change in philosophy.
It really is a shift in mindset. It's the moment when we stopped looking at brute force as the only way to solve a problem and started looking for precision.
Precision. Yeah, I like that. Before we get into the drama, though, and there's a lot of drama here from life and death decisions to just insane global logistics, we need to lay down the groundwork for you, the listener. We're doing a deep dive into a landmark source today.
A very heavy source.
Oh, yeah. The title is Comparison of Fondaparinux and Enoxaparin in Acute Coronary Syndromes.
Which is a very clinical title for what is actually a very dramatic trial.
Yeah, they don't exactly write these for Hollywood, but this was published in the New England Journal of Medicine on March 14th, 2006. And I actually have to read the credits here because the sheer number of people involved in steering this ship is just staggering.
You're going to read all of them.
I am. I have to. The writing committee includes Salim Yusuf, Shamir Armeta, Susan Krolavicius, Rizwan Afzal, Janice Pogue, Christopher B. Granger, Andrzej Budaj, Ron J.G. Peters, Jean-Pierre Basson, Lars Wallentin, Campbell Joyner, and Keith A. Fox.
Wow. And, that is literally just the tip of the iceberg. They represent the fifth organization to assess strategies in acute ischemic syndromes investigators.
Yeah, it's a mouthful.
It is. But they're generally known in the medical world simply as OASIS 5.
OASIS 5, which, it sounds like a secret government project or something, doesn't it?
Right, like an action movie?
But in reality, it was this massive, coordinated international effort. We're going to get into the scale of it a bit later because the numbers are frankly mind-boggling. But first, let's just set the stage. We are dealing with the human heart, specifically acute coronary syndromes.
ACS.
Right, ACS. And the hook here, the thing that I think keeps cardiologists up at night, is what I call the double-edged sword. It seems like every treatment in this specific field comes with a price tag attached, and I don't mean money.
No, absolutely not money. The currency here is risk. Physiological risk to the patient.
So let's break this down for everyone listening. When a patient comes in with an acute coronary syndrome, say unstable angina or a full-blown heart attack, what is physically happening inside their chest right at that moment?
Okay, so imagine a plumbing system, right?
Yeah.
But instead of water, you have this highly reactive, life-sustaining fluid that needs to be pressurized, and it has to be moving constantly. In ACS, one of the main pipes, the coronary arteries that actually supply the heart muscle itself, gets a blockage.
Like a clog.
Usually, a plaque is ruptured on the wall of the artery, and the body, doing what it's supposed to do, thinks it has a cut, so it rushes to seal it up. It forms a clot, which we call a thrombus.
So the body's just trying to heal itself, but in doing so, it's actually blocking the blood flow to the very muscle that pumps the blood.
Precisely. The scab, so to speak, is forming on the inside of the pipe. And this starves the heart muscle of oxygen. That starvation is ischemia.
And if that lasts too long?
The muscle dies. And that is a myocardial infarction, a heart attack.
Okay, so the mission for the doctor is pretty clear. You have to bust that clot. You have to thin the blood and get things flowing again immediately.
You have to interrupt the clotting process.
Mm-hmm.
We use anticoagulants and antiplatelets for this. We're essentially telling the body, stop trying to heal this rupture because your healing process is killing the patient.
But here's the catch, and this is really where the central tension of this whole deep dive lies. If you turn off the body's natural ability to clot, you bleed. And you don't just bleed at the site of the heart. You can bleed literally anywhere.
Anywhere. The brain, the stomach, the nose, the site in your arm where they put the IV in.
That is the ultimate paradox. The exact mechanism we need to stop the heart attack, which is thinning the blood, is the exact same mechanism that causes hemorrhage. And for decades, this was basically viewed as an unavoidable trade-off.
It was. It was a hierarchy of fears for the doctors.
A hierarchy of fears. What do you mean by that?
Well, the fear of the heart stopping was so immediate and so great that the fear of a bleeding complication was secondary. Bleeding was seen as a nuisance. A nasty side effect, sure, but not a failure of the treatment itself. It was just the cost of doing business to save the heart.
But the OASIS 5 investigators, this massive international group we just mentioned, they challenged that whole premise. They looked at the data and said, wait a minute, bleeding isn't just a side effect, it's a killer.
Yes. The source material is very specific and aggressive about this point. They link bleeding directly to higher risks of death, stroke, and future heart attacks down the line. So the new question became, can we find a way to stop the clot without causing the bleed?
Can we separate the efficacy from the safety?
Exactly. Can we have our cake and eat it too?
It's the search for the holy grail of cardiology, the perfect anticoagulant.
And that search led to a massive showdown between two very different drugs.
Right, the contenders. Let's introduce them. In the red corner, we have the reigning champion of the year 2006, Enoxaparin.
Enoxaparin is what we call a low molecular weight heparin. At the time of this trial, this was the absolute gold standard in hospitals worldwide.
He was the heavyweight champ.
It was. It had beaten the older, clunkier drugs like the original unfractionated heparins. It was reliable. Every doctor knew exactly how to dose it, and it worked. It stopped clots.
But from what I understand, it was a bit of a blunt instrument, wasn't it?
That's a good way to put it. It's biological. It's derived from animal sources,
Really?
usually porcine intestines, actually.
Pig intestine.
Right, so it's this complex soup of molecular chains of all different lengths. It hits multiple targets in the clotting cascade. It inhibits factor XA, which is good, but it also inhibits thrombin, which is factor XAN. It's powerful, but it's really messy.
So if enoxaparin is a shotgun, spraying pellets everywhere just to make sure it hits the target, let's talk about the challenger, Fondaparinux.
Fondaparinux is a completely different beast. First of all, it is not biological. It is entirely synthetic.
Designed in a lab.
Exactly. It is a synthetic pentasaccharide. It's essentially a sugar molecule designed atom by atom to do exactly one specific thing.
And what is that one thing?
It binds to antithrombin and inhibits only factor XAN, nothing else.
Okay, we need to deep dive into the biology here for just a second for our listeners, because factor XAN sounds like a sci-fi villain. Why focus on XAN? Why is that the ultimate target?
Think of the whole clotting process in the body as a waterfall, a cascade. One enzyme activates the next, which activates the next, gaining momentum. Factor SAC sits right at the critical bottleneck of this cascade. It's the amplifier.
The amplifier, how does it amplify?
One single molecule of factor SAC leads to the generation of about 1,000 molecules of thrombin. And thrombin is the glue that actually forms the physical clot.
Okay, so if you stop the thrombin, like the shotgun enoxaparin does, you are essentially mopping up the water at the bottom of the waterfall.
Correct. You're fighting the flood after it's already started.
Yeah.
But if you stop factor SAC, you are turning off the tap at the top.
Yeah.
You prevent the amplification entirely.
So the theory was that by hitting STAC, you could be incredibly efficient at stopping clot generation without having to paralyze the entire downstream clotting system.
That was the hypothesis. Fondaparinux was the sniper rifle. One shot, one kill, no collateral damage. Could this synthetic sniper match the brute force of the shotgun in stopping heart attacks, but be way safer for the patient?
To find out, they didn't just run some small clinic experiment. They launched Oasis 5. And I want to pause on the scale of this setup, part one of our deep dive, because it is genuinely hard to wrap your head around the logistics here.
Monumental is the word.
20,078 patients.
That's the population of a small town, all experiencing a severe cardiac event.
And they were spread across 576 centers in 41 different countries.
Just think about the sheer administrative logistics of that. You have hospitals in Canada, Brazil, India, Poland, Australia, all trying to follow the exact same rigid protocol.
Different languages, different standard practices, different healthcare systems entirely.
Right. To coordinate a trial of this magnitude requires a level of organization that is practically military.
And it gives the data incredible weight, doesn't it? Like, if you do a study in one fancy hospital in Boston, skeptics can say, well, maybe that only works in Boston with Boston doctors, but when you do it in 41 countries,
it becomes universal. It proves that the biological mechanism holds true regardless of where the patient lives, what their background diet is, or their genetic makeup. It strips away geographical bias.
Let's talk about these 20,000 patients. Who were they?
These were people in real trouble. They came to the emergency room with acute chest pain. They had unstable angina or myocardial infarction without ST segment elevation.
Which doctors call NSTEMI.
Right. And they were mostly older. The mean age in the trial was around 67 or 68. A lot of them already had diabetes, hypertension, or previous heart attacks. So these were very sick, very vulnerable patients.
Now, the methodology of the trial itself, I love this part. They used a double-blind and double-dummy design. Now, double dummies sounds like an insult or a magic trick, but it's actually really hard on the patients, isn't it?
It's a significant burden for the patient, yes, but absolutely necessary for the integrity of the science.
Walk us through that patient experience. If I'm a patient enrolled in Oasis 5, what is happening to me every day in that hospital bed?
Well, the standard drug, Enoxaparin, has to be given twice a day. But the new drug, Fondaparinux, only needs to be given once a day.
Okay, so if the doctor just gave you the active drug you were assigned to, you would know immediately which group you were in just by counting the injections. You'd think, hey, I got 2 shots today. I must be on the older drug, enoxaparin.
Exactly. And knowing which drug you are on completely ruins a clinical trial.
Because of the placebo effect?
The placebo effect, yes, but also observer bias. The doctor or the nurse might subconsciously treat you differently if they know you're on the experimental drug. So to keep it totally blind, everyone had to get the exact same number of injections every single day.
So how do they pull that off?
If you were randomly sorted into the Fondaparinux group, you got your real active drug once a day, plus you got a dummy shot, a placebo, basically just saline that looked exactly like the enoxaparin shot.
And if you were in the enoxaparin group?
You got your active enoxaparin twice a day, plus a dummy shot that looked identical to the Fondaparinux syringe.
Man, that is a lot of needles for these poor patients.
It is. The treatment lasted for a mean of 6 days. But it meant that absolutely nobody, not the patient, not the bedside nurse, not even the head of cardiology at that hospital, knew who was getting what.
It strips away all the noise.
It leaves only the raw, undeniable truth of the drug's performance.
Okay, so the stage is perfectly set. We have the sniper versus the shotgun, 20,000 patients, 41 countries. Let's get to the results. Part 2 of our deep dive. The primary outcome, the fight against ischemia.
The primary goal. Did it actually stop the heart attacks from happening?
The source material explicitly says the objective here was non-inferiority. Now, to an outsider, non-inferiority sounds kind of weak, like I want to prove I'm not worse than the other guy. Why wouldn't they aim for superiority? Why not try to be the absolute best?
That's a really crucial nuance in modern pharmacology. When you are going up against a reigning champion like enoxaparin, you have to realize that medicine has basically hit a ceiling effect in terms of efficacy.
A ceiling effect.
Yes. Enoxaparin is already really, really good at stopping clots. To be significantly better at stopping clots than enoxaparin, you would likely have to thin the blood to a degree that is simply incompatible with life.
Ah, I see. You can't kill the clot twice.
Exactly. If the artery is open, it's open. So the statistical goal wasn't to be stronger, it was to prove that this new, highly precise mechanism could hold its own against the heavyweight champion without losing ground. If it could do that, then its other theoretical advantages like safety would make it the overall winner.
So day 9 of the trial, they checked the scorecard. The primary metric was a composite of death, myocardial infarction, or refractory ischemia. What were the actual numbers?
In the Fondaparinux group, 579 patients had one of those events. That's 5.8%.
And the enoxaparin group,
573 patients.
which is 5.7%.
5.8% versus 5.7%.
The hazard ratio was 1.01.
That is basically a statistical tie, a dead heat. It is a dead heat. And in the medical world, for a non-inferiority trial, that is a massive victory. It formally proved that the sniper approach targeting just factor SOS6 was completely sufficient to protect the heart. You didn't need the messy multi-target shotgun approach to get the job done.
So round 1 ends in a draw. Now, if you're a doctor reading this in 2006, you might be wondering, well, if the drugs work exactly the same, why should I switch? I'm comfortable with enoxaparin. Why rock the boat?
And that right there is exactly where the study pivots.
Yeah.
That is where Oasis 5 goes from being an interesting trial to a landmark piece of medical history.
Part 3. The game changer. Safety and bleeding.
This is the data that made the auditorium go completely quiet when it was first presented at the cardiology conferences.
They looked at major bleeding at 9 days. Now, I want to be really clear with the listener about what major bleeding actually means in this context. We aren't talking about your gums bleeding when you brush your teeth too hard.
No, not at all. The definition of major bleeding in these clinical trials is incredibly severe. We are talking about intracranial hemorrhage, which is bleeding directly into the brain, or retroperitoneal bleeding.
Retroperitoneal bleeding. Let's unpack that. Why is that one so notoriously bad?
Because the retroperitoneal space, which is the area behind the abdominal cavity where your kidneys sit, can hold a massive amount of blood before you or the doctor ever notice it from the outside.
So a patient could just be bleeding internally, filling that space up.
Exactly. A patient could lose liters of blood internally. Their blood pressure starts tanking, their heart rate spikes, they go into hypovolemic shock, and you might not see a single drop of blood on the bedsheets. It's a silent killer.
That is terrifying.
It is. The major bleeding category also included any bleeding that requires surgical intervention to stop, or bleeding that requires multiple blood transfusions. These are undeniably life-threatening events.
Okay, so let's look at the safety scoreboard. Remember, on stopping the heart attack, the efficacy was a dead tie. But for major bleeding at day 9, in the enoxaparin group, the standard of care, there were 412 major bleeding events. That is 4.1% of the patients.
Roughly 1 in every 25 patients had a life-threatening bleed.
And in the Fondaparinux group,
217 events. That is 2.2%.
whoa, 4.1% down to 2.2%.
That translates to a hazard ratio of 0.52.
A 48% reduction. They basically cut the major bleeding risk right in half.
In the world of clinical pharmacology, seeing a 50% reduction in a major safety endpoint like this is almost unheard of. Usually, investigators are fighting tooth and nail for a 10 or 15% relative improvement. A 50% reduction is an absolute landslide. The p-value on this was less than 0.001.
Which means what, statistically speaking?
It means the probability of this difference happening just by random chance is less than 1 in 1,000. The data is real. It's incredibly robust.
And this wasn't just, minor nuisance bleeds being reduced. The source explicitly notes they saw significant reductions in fetal bleeding.
Yes. Literally fewer people bled to death. Fewer people needed trauma surgeons to cut them open to find a bleeding artery. It was a comprehensive, undeniable victory across the board for this synthetic drug.
I have to ask about the subgroups here, because so often on this show we see a drug that looks amazing on average, but then you dig into the appendix and find out it's actually super dangerous for older people or people with kidney problems.
That is a critical point, especially when you're dealing with anticoagulants. Most low molecular weight heparins, like enoxaparin, are cleared from the body by the kidneys.
Explain that mechanism for us. How does that work?
Think of the kidney as your body's filter. It takes the active drug out of your bloodstream and puts it into the urine to be excreted. If your kidneys are failing, if the filter is clogged up, the drug just stays circulating in the blood.
It accumulates over time.
Right. You give the patient their second dose 12 hours later, but the first dose hasn't left the body yet. Then you give the third dose. The levels of anticoagulant in the blood get higher and higher, way above the safe therapeutic range. And suddenly, the patient's blood is like water, and they bleed out.
And in this OASIS 5 population, with an average age of 67, a significant portion of these people must have had bad kidneys, right?
Many of them did. And this is exactly where Fondaparinux shined the brightest. In patients with severe renal impairment, which means a creatinine clearance below 30 milliliters per minute, the major bleeding rate with enoxaparin was 9.9%.
Basically 10%. 1 in 10 of these patients with bad kidneys had a major life-threatening bleed on the standard drug. That sounds like playing Russian roulette with the patient.
It is unacceptably high by modern standards. But with Fondaparinux, the bleeding rate in that exact same severe kidney disease group was 2.4%.
From 10% down to 2.4%.
It effectively neutralized the excess risk of renal impairment. It turned a very high-risk patient back into a standard-risk patient.
That is just incredible. Okay, so we have firmly established that Fondaparinux is exactly as good at stopping the heart attack clots, and it is twice as safe when it comes to causing severe bleeding. But I want to play devil's advocate for a second here.
Please go ahead.
So what?
So what?
Yeah. I mean, obviously bleeding internally is bad. Nobody wants a blood transfusion. But if I am in the ER having a massive heart attack, my primary fear is dying from the heart attack. I would take a bleeding complication over a tombstone any day of the week, right?
That is the exact intuition most people have.
Yeah.
And honestly, even the smartest cardiologist had that exact same intuition for a long time. Save the heart muscle now, worry about the blood loss later. But the findings of OASIS 5 destroyed that argument completely.
And this brings us to part 4 of the deep dive, the ripple effect, the undeniable link between bleeding and death.
This right here is the scientific core of our entire discussion. The study definitively proved that bleeding and dying are inextricably linked. Bleeding is not an isolated event you just patch up. It has a long, dark tail.
How? Explain the actual physiological mechanism for us. How does a bleed today end up killing you 3 months from now?
It is a brutal domino effect. Let's walk through it step by step. A patient is in the hospital for a heart attack. They're on blood thinners, and suddenly they have a major internal bleed. What is the very first thing the medical team has to do?
They stop all the anticoagulants. They have to save them from bleeding out.
Correct. You have to immediately stop the enoxaparin, stop the aspirin, stop everything to let the blood clot and halt the hemorrhage. But remember why the patient is there in the first place. They have a newly ruptured plaque in their coronary artery. They're in a highly prothrombotic clot-forming state.
So you are basically stripping away their armor right at the exact moment when they need it the absolute most.
Exactly. It's a phenomenon called the rebound effect. You stop the suppressing drugs, and the body's clotting system, which was fighting against those drugs, roars back to life, often with a vengeance. So the doctors manage to stop the bleeding in the stomach, but 2 days later, the patient has a massive fatal heart attack because the clot in the heart reformed.
Okay, that makes perfect sense. That's one mechanism. What else is happening to the body during a major bleed?
Massive hemodynamic stress. When you bleed internally, your total blood volume drops significantly. Because of that, your blood pressure drops. To compensate and keep you alive, your heart rate spikes. Tachycardia.
And this is a heart that is already damaged and starving for oxygen from the initial heart attack.
Right. You are asking a sick, ischemic heart to essentially run a marathon just to maintain basic blood pressure. It can't keep up with the demand. The ischemia worsens rapidly. The heart muscle dies faster.
Wow. And what about the transfusions they give you to replace the blood? Don't those fix the volume problem?
Transfusions are not benign. Putting someone else's banked blood into your body causes a systemic inflammatory response. It can trigger severe immune reactions. Stored blood doesn't release oxygen to the tissues as efficiently as fresh blood. The data consistently shows that heart attack patients who receive blood transfusions have significantly worse outcomes than those who don't.
So simply by preventing that initial bleed from happening in the first place, Fondaparinux prevents this entire cascading spiral of disaster.
Yes, and the mortality data from the trial proves it beyond a shadow of a doubt.
Let's look at those mortality numbers. At 30 days out, 1 full month after the treatment.
There were significantly fewer deaths overall in the Fondaparinux group. 295 total deaths versus 352 deaths in the Enoxaparin group.
That is 57 lives saved just in this specific study population over 1 month.
And that trend just continued out to 6 months. 180 days later, the survival curves were still separating. 574 deaths on Fondaparinux versus 638 on Enoxaparin.
This source material makes a very bold declarative claim here. I actually have it highlighted in my notes. The authors write, almost the entire difference in mortality between the groups could be attributed to the lower rate of bleeding with Fondaparinux.
That is a profound statement for a medical journal. They are explicitly saying, we didn't save these lives because we were fundamentally better at treating the heart clot directly. We saved these lives because we didn't actively hurt the patient with our own treatment.
It totally redefines the word efficacy. Efficacy isn't just, does the drug do the one specific thing it was designed to do? It's, does the patient actually survive the hospital stay?
And survival depends heavily on safety. Safety is efficacy. You cannot separate the two concepts anymore. OASIS 5 married them permanently.
Which perfectly transitions us to the concept of net clinical benefit, part 5 of the deep dive.
This is essentially the accountant's view of medicine. You have to balance the ledger.
You take all the bad things the disease does, death, heart attack, refractory ischemia, and you add the bad things the drug does, major bleeding. You put them all in one big bucket and treat them all as equal failures of the system.
Because to the patient lying in the bed, they're all catastrophic failures. The patient doesn't care if they die from a blocked artery or a bleeding brain. They just want to go home to their family.
And when you look at that composite score, that net clinical benefit at day 9.
Fondaparinux had a failure rate of 7.3%. Enoxaparin was up at 9.0%.
That's a hazard ratio of 0.81, a 19% relative improvement.
A nearly 20% better outcome when you zoom out and look at the whole patient, not just their heart. That is the very definition of a superior overall strategy.
And we should briefly touch on the economics of this. The source mentions this somewhat obliquely, but it's really important for healthcare systems.
It's huge. If you have fewer massive bleeds, you have fewer emergency surgeries to stop those bleeds. You use thousands of fewer units of donor blood for transfusions. Patients spend fewer days in the intensive care unit.
So they go home sooner, freeing up beds. It literally saves lives, and it saves millions of dollars. Honestly, it sounds too good to be true. And usually on the show, when we find a medical breakthrough that sounds absolutely perfect, there is a catch.
There is always a catch in biology.
Part 6. The nuance. The hiccup. the catheter thrombus?
This is a fascinating subplot in the Oasis 5 trial. It's a mechanical issue that almost derailed the whole billion-dollar thing.
So, a subset of the patients in this trial, roughly 6,000 of them, needed a procedure called PCI, percutaneous coronary intervention.
Most people know it as an angioplasty. The interventional cardiologists thread a long, very thin plastic tube, a guiding catheter up through the femoral artery in the leg, or the wrist, all the way to the heart so they can physically open the blockage with a balloon or put in a metal stent.
Now, during the trial, the Data Safety Monitoring Board, these are the independent statisticians watching the raw numbers in real time to make sure nobody is getting hurt. They noticed something really worrying.
They saw a slight but distinct increase in guiding catheter thrombus in the patients receiving Fondaparinux.
What does that actually mean?
It means that tiny blood clots were physically forming on or inside the plastic catheter itself while it was inside the patient's body.
Wait, the drug was supposed to stop clots from forming. Why was it letting clots form right on the surgical tool?
This goes right back to the sniper analogy we used earlier. Fondaparinux is incredibly beautifully precise. It inhibits factor Savi perfectly, but it does not inhibit factor tyrosine directly.
Okay.
And it turns out plastic is a foreign material to the human body. When blood touches that raw plastic tubing, it strangely activates the clotting system through something called the contact pathway. And this pathway very rapidly generates massive amounts of thrombin right on the surface of the plastic.
And since Fondaparinux basically ignores thrombin entirely,
A thrombin was completely free to stick to the plastic and form a dangerous clot. Enoxaparin, because it's that messy biological shotgun, inhibits thrombin too, so it prevented this specific plastic reaction.
wow. So the drug was almost too smart for its own good. It was so hyper-focused on the internal biology of the heart plaque that it completely missed the physical chemistry of the plastic tube being shoved in.
That is a genuinely great way to summarize it.
So this sounds incredibly dangerous. Clots forming on a catheter that's sitting inside the coronary artery could easily shoot off and cause a massive stroke or an immediate heart attack. Did it ruin the trial results?
It was a very serious risk. The rate of this happening was 0.9% with Fondaparinux versus 0.3% with Enoxaparin. So it was still a rare event, but it was 3 times higher with the new drug.
So how did they fix it? Did they have to cancel that arm of the trial?
No. The operations committee realized very quickly that this was a mechanical procedural issue, not a fundamental failure of the drug's biology. They issued an urgent trial amendment. They essentially told all the doctors, look, if you're taking a patient to the lab for PCI, just give them a small intravenous shot of standard unfractionated heparin while they're on the table.
The really old school heparin.
Exactly, just a splash. Just enough extra thrombin inhibition to coat the plastic catheter and handle that specific contact activation during the 30-minute procedure.
They basically gave the sniper a sidearm for close quarters combat.
Exactly.
Hmm.
And here's the truly amazing part about the data. Even with that procedural hiccup, even with that slight increase in catheter clots, the PCI patients still did significantly better on Fondaparinux overall.
How is that logically possible if they were forming clots on the tubes?
Because the reduction in major bleeding at the physical access site, the place in the groin where they poked the giant hole in the femoral artery to get the tubes in that reduction, was so massive. Bleeding at the access site dropped from 8.1% with enoxaparin down to just 3.3% with Fondaparinux.
So the systemic safety benefit of preventing those huge groin bleeds was so powerful it mathematically outweighed the slight procedural complication of the catheter.
Yes. And once they formally added that simple heparin flush protocol, it became a complete non-issue in clinical practice. It's a beautiful example of how clinical science adapts in real time. You find an unexpected problem, you understand the exact physical mechanism of that problem, and you tweak the protocol.
Yeah.
You don't throw out a massive medical breakthrough just because it needs a slight adjustment.
Before we wrap up here, I really want to circle back to the loser of this heavyweight fight, enoxaparin. Why exactly was it so much bloodier? Part 7. The anatomy of failure.
It's really interesting to analyze why the accepted standard of care failed so spectacularly on safety. The experts in the source material offer a few really compelling theories.
Let's hear theory 1.
Mechanism. We keep coming back to it. Enoxaparin strongly inhibits thrombin. Thrombin is the final step in the cascade, the ultimate glue. If you inhibit the glue too much, the body literally cannot seal up the tiny micro tears that happen in your blood vessels every single day, let alone the giant puncture site from a surgical needle. Factor AZ inhibition, on the other hand, seems to leave just enough basal clotting ability intact to handle everyday tissue maintenance while still aggressively stopping the runaway pathological clot in the heart.
So it modulates the system rather than completely obliterating it.
Right, it preserves hemostasis. Theory 2 is much simpler. Dosing. The standard recommended dose of enoxaparin across the world was 1 milligram per kilogram of body weight, twice a day.
That's just what everyone used for years.
But the authors openly speculate in the paper. Was that dose just empirically too high all along? Have we simply been systematically overdosing millions of patients for years because we didn't know any better?
But they couldn't just test a lower dose in this specific trial to see.
No. Ethically and scientifically, you can't. You have to test your new drug against the legally approved standard of care dose. If they had arbitrarily used a lower dose of enoxaparin and it didn't stop the heart attacks as well, the medical community would have crucified them. People would have said, you deliberately underdosed the control group just to make your new drug look better.
Wow. So enoxaparin was essentially trapped by its own historical success. It couldn't evolve.
In a way, yes, it was. And finally, there's the rebound effect we discussed at length. Because enoxaparin directly caused more initial bleeding, doctors were forced to stop giving it. Because they stopped giving it abruptly, those patients suffered rebound clots and died. So enoxaparin's fundamental lack of safety directly caused its long-term lack of efficacy.
It's just a tragic, vicious loop.
It is, but rigorously identifying that loop through OASIS 5 allowed the medical community to finally break it.
So let's get along. We have traveled from the microscopic coagulation cascade to 41 different countries, through the internal filter of the kidneys and right into the high-stress environment of the catheter lab. The conclusion.
If we have to summarize the legacy of OASIS 5, it really comes down to 3 unshakable pillars.
Let's hit pillar 1.
Efficacy. The synthetic sniper, Fondaparinux, is exactly as good as the biological shotgun, enoxaparin, at immediately stopping acute heart attacks.
Pillar 2.
Safety. Fondaparinux cuts major life-threatening internal bleeding in half. It is radically, undeniably safer across the board, especially for the most vulnerable patients.
In pillar 3.
Survival. Because it prevents that catastrophic bleeding, it directly saves lives. It reduces long-term mortality out to 6 months significantly.
And the final verdict from the authors.
The authors conservatively call it an attractive option in the paper. I would go further. I'd call it a massive paradigm shift. It proved once and for all that in the acute treatment of severe heart disease, less can actually be more. Precision definitively beats brute power, and patient safety is the ultimate key to patient survival.
It's a profound lesson that goes way beyond just cardiology, doesn't it?
Absolutely. It changes how we think about risk everywhere.
Which brings me to our final provocative thought for today. We always like to leave you, the listener, with something bigger to chew on after all these statistics.
For me, the ultimate takeaway from this whole deep dive is redefining the definition of winning.
How so? Unpack that for us.
In medicine, in corporate business, and our daily lives, we so often focus entirely on the primary metric. Did we shrink the tumor? Did we make the quarterly sales quota? Did we stop the clot in the artery? But OASIS 5 teaches us that if you achieve your primary goal, but you leave a massive trail of destruction behind you in the process, like severe bleeding complications, you haven't really won at all.
You've just traded one catastrophic problem for a different catastrophic problem.
Exactly. True success is maximizing the net clinical benefit. It's looking at the entire holistic picture. It's understanding that the method you use matters just as much as the result you get. A precise solution that solves the immediate problem and protects the overall system is infinitely better than a blunt solution that just solves the problem at any cost.
That is a remarkably powerful place to end. Precision, balance, looking at the whole picture instead of just the immediate crisis.
It's a funnel effect in action, really.
It certainly is. This has been an absolutely incredible deep dive. Honestly, who knew a tiny synthetic sugar molecule could be so intensely dramatic?
Science is always dramatic if you just look close enough at the data.
Thank you so much for breaking this complex, massive trial down with us today.
My absolute pleasure. Anytime.
And to you, our listeners, thank you for sticking with us through the heavy science, the intense statistics, and the human story behind it all. We hope you look at your own complex challenges a little differently now, maybe looking for the precise sniper rifle solution instead of always reaching for the shotgun.
Indeed.
Thank you for watching The Funnel Effect.